Brigham Women's Hospital in Boston. Her abstract will be the SOLID-TIMI 52 study, and I want to welcome Dr. O'Donoghue to the podium. Thank you.
Good morning. So on behalf of the SOLID-TIMI 52 investigators, it's my pleasure to present to you the primary results of the SOLID-TIMI 52 trial. Lipoprotein-associated phospholipase A2, or LPPLA2, is believed to contribute to atherosclerosis through pathways of inflammation. There are numerous epidemiologic studies that have shown that higher levels of LPPLA2 are associated with an increased risk of cardiovascular events. Darapladib is an oral direct inhibitor of the LPPLA2 enzyme that reduces LPPLA2 activity both in the circulation as well as within the atherosclerotic plaque. In phase 2 testing, Darapladib did not modify the coronary atheroma volume, but appeared to halt the progression of the necrotic core as compared to placebo on a background of statin therapy. The efficacy and the safety of Darapladib has now been evaluated in 2 large phase 3 clinical trials. The results of the Stability trial have been previously presented and published. In brief, Stability enrolled nearly 16,000 patients with chronic coronary heart disease with high-risk features, randomized them to Darapladib or placebo on a background of optimal care therapy, and followed them for a median of 3.7 years. The trial did not meet its primary endpoint of cardiovascular death, MI, or stroke, but when they examined secondary endpoints, Darapladib nominally reduced the incidence of both major coronary events and total coronary events. SOLID-TIMI 52 is the current trial that I'll be presenting. This is a patient population of ACS patients. In detail, this is the study design. SOLID-TIMI 52 enrolled 13,026 patients. These were high-risk patients enrolled within 30 days of hospitalization with an acute coronary syndrome. Patients were across the spectrum of ACS, including unstable angina, non-STEMI, or ST elevation MI. The use of guideline-recommended therapies were strongly encouraged throughout the duration of the trial. Patients were randomized in a double-blind design to either Darapladib or to placebo. The median duration of follow-up was 2.5 years, and the primary endpoint was coronary heart disease death, MI, or urgent coronary vascularization for myocardial ischemia. These are the primary results of the trial. Darapladib did not reduce the incidence of the primary endpoint, the composite of CHD death, MI, or urgent coronary vascularization. Similarly, Darapladib had a neutral effect on the risk of the secondary endpoint, the composite of cardiovascular death, MI, or stroke. You can see that the curves are nearly superimposed throughout the duration of the trial, both through the early period as well as through the later duration of follow-up. Looking at the safety data, overall, the incidence of serious adverse events was similar for patients who were treated with Darapladib or with placebo. As had been anticipated in the phase 2 program, the incidence of odor-related events as well as diarrhea was higher for patients who were treated with Darapladib as compared to placebo, and this contributed to a higher discontinuation rate that was attributed to adverse events for patients treated with Darapladib. The incidence of cancers was similar between the 2 treatment arms. So in summary, in patients after an acute coronary syndrome, direct inhibition of LPPLA2 with Darapladib on a background of optimal medical therapy did not reduce the risk of major coronary events. In turn, these findings do not support a role for LPPLA2 inhibition in patients after an acute coronary syndrome. I think, however, this does not argue against the central role that inflammation is believed to play in atherogenesis, but rather highlights some of the unique challenges that are faced on the road to developing anti-inflammatory therapeutics, as reliable surrogate endpoints are currently lacking in order to gain insights into efficacy before phase 3 testing. Thank you.
Thank you, Dr. O'Donoghue. Questions from the audience, please? Yes. Please identify your name and organization, please.
Ed Sussman with MedPage Today. The results of stability and solid mean that we don't have to learn how to pronounce the name of this drug.
I think both Darapladib and LP-pLA2 have been a mouthful for people to pronounce. But I think that the important point is that conceptually, I think that we all believe that inflammation plays really a crucial role, and there are certainly a lot of novel anti-therapeutics or anti-inflammatory therapeutics that are being developed. But the issue may be that inflammation is just such a complex and redundant series of pathways that if you perhaps zero in on too specific of a target, there's compensation along other pathways. But that's just speculation at this point.
Are there other studies involving this agent, or have we seen the last of it?
Well, the company is still currently evaluating other potential uses for the drug, but at this time, there's nothing planned in the immediate future within the realm of cardiovascular disease right now.
Additional questions? Well, thank you, Dr. O'Donoghue. Also want to introduce our third spokesperson, Dr. Keith Fox, who is the chair of the ESC Scientific Sessions, who will be at the front of the room and will be available